Hello class, this is Dr. Anderson and we are back to talk about pulmonary pathophysiology. This presentation of course is tailored towards the things nurse and anesthesia students would need to know for their board exams. So I have, in some situations, I have just kind of a laundry list of things we need to cover, and then we're going to do some exploration of chronic obstructive pulmonary disease versus restrictive disease, and then some situations where pulmonary disease then can result in cardiovascular disease. So here's a first set of learning objectives I'd like for us to talk about. We want to talk about why somebody would feel breathlessness or feel shortness of breath. And that's going to have to do with elevated CO2, a lack of O2, though not as much with lack of O2, and congestion in the chest. We're going to talk about Cheynestokes respiration. It's not that you would see that every day, but there's an interesting alteration in feedback that makes that worth talking about. We're going to talk about how changes in capillary permeability and hydrostatic pressure can lead to pulmonary edema. Talk about 100% oxygen and how you have to be careful with that, and atelectasis, which is collapse of the lung, and pneumothorax. So Cheynestokes, notice we're starting at FRC. Remember, at FRC we're at the end of a normal breath, and notice for a period of time this person is not breathing at all, and as they do, their PCO2 is rising. And this increase in CO2 should be setting off respiration, but it doesn't seem to be doing that for, a good 10 seconds here. And then the person starts to breathe, and then they're breathing, and then they're really breathing, and they're blowing off CO2 like crazy. And that should inhibit ventilation, but it doesn't right away. And so they continue to blow off CO2 till they blow off so much CO2 that they just stop altogether. And they just stop altogether, and they stop, and while they've stopped breathing, CO2 is rising, and it's rising, and it's rising, and it should have set off ventilation, but it's not, and it continues to rise, and then it sets off ventilation, and then we really get going, and then we're hyperventilating and blowing off CO2, and we should have stopped hyperventilating, but we don't, we keep going. So there's a delay in the response. Typically what this means is your patient is in a great deal of difficulty. They have a head injury. They are in the process of dying. Their respiratory centers are going. People with in the end stages of dementia can exhibit weird kind of breathing like this. This can be exacerbated with heart failure. So one theory of Cheynestokes used to be that because there was a delay in delivering blood to the brain, the central chemoreceptors weren't picking up the signal. That can influence Cheynestokes, but heart failure alone doesn't do it. It's because the heart failure has compromised blood flow to the brain, and the respiratory centers are damaged, and then they're not responding as well to the blood. So the things I want you to take away about Cheynestokes respiration is that Cheynestokes is a situation where we have altered feedback and a delayed response, and it indicates there is a neurological problem in the respiratory centers. I want to know where my oxygen slide is. I seem to be missing a slide, so forgive me. If you give someone 100% oxygen, some of you in nursing may have heard the phrase, oxygen is a drug. The thing is, Oxygen in high concentrations will flood the body with oxygen. There are reactions, and oxygen can turn into something called superoxide, which is an oxygen with an extra electron. That makes it a free radical, and that makes it going around doing damaging things. So the first message here is there might be really good reasons to put someone on 100% oxygen. They need 100% oxygen to get a decent saturation. They need 100% oxygen because they've just had a massive abdominal surgery, and that 100% oxygen will help them heal. But you really don't want to do that for more than 24 hours because you start getting the production of free radicals. The other reason has to do with ventilation perfusion differences and metabolism differences. Most people have a respiratory exchange ratio or a respiratory quotient on a mixed diet of about 0.8. Now remember, what is this? Well, VCO2 over VO2. Meaning we use more O2 than we return in CO2. So if you think about somebody's lungs, and I'm just going to draw a very crude diagram, they have nitrogen, they have CO2, and they have O2. Well, if you're using the oxygen and adding CO2, but you're using more oxygen than you're putting back in CO2, that could cause kind of a vacuum, couldn't it? But it doesn't happen in healthy people or in people breathing ambient air because of this guy right here. We hardly ever talk about nitrogen, but this is a big thing that nitrogen does for us. Nitrogen fills in the gaps. If you use more O2 than you return in CO2, then nitrogen comes in and makes sure that the inside of your lungs is, 0 or +1 or -1 in terms of atmospheric pressure. It helps make sure that there are no weird pressure gradients inside your lungs. Okay, if someone is breathing 100% oxygen, guess what? We get rid of nitrogen. Somebody's just breathing 100% oxygen, but they're not putting back CO2 in replacement. And therefore the pressure in the lungs gets lower and lower and lower until it collapses. And I'll just put C. I won't bore you with writing out the word collapse. It collapses or does something called alactasis. I just missed a syllabus. Atalactasis. There it is. All right. When there are pressure problems and a lung collapses, that's something called a pneumothorax. Remember, we have this intrapleural space that's supposed to be somewhat negative. So say between -4 and -8 millimeters of mercury. Here we have a situation where the lungs have been injured, atmospheric air is entering this space, and the lung is collapsing. Here I have a situation where the injury is from the outside, air comes in, equilibrates with atmospheric pressure, and the lung collapses. Here we have a situation where the pressure in the interpleural space is starting to get higher than the pressure in the lungs, and an 100% oxygen atalactasis is a way that can happen, and we might even expect both of them, or there's some pressure problem here that's actually compressing the lungs. So the a nurse anesthetist, we would invite them to make their comments during class. But if you can get a good saturation for a patient on 60% oxygen, then that's what you're going to use. If you work at the VA Medical Center and you have a policy that everybody gets 100% oxygen, well, then you can't titrate it maybe the way you would do in another hospital. And I'll be interested in the nurse anesthetist's take on this. But there are some pressure inequities that are introduced with long-term oxygen, in addition to the fact that long-term high oxygen can lead to the production of free radicals. So overexposure to oxygen can actually cause a condition we call oxygen toxicity. All right, now we're going to talk a little bit about COPD. There's actually an enzyme in the matrix called alpha-1 antitrypsin. Alpha-1 antitrypsin is an enzyme that counters another enzyme called elastase. So you have a balance between increasing the matrix and decreasing the matrix. You want to break down the matrix, but you want to build the matrix, and these two need to be in balance. If there's something wrong with this enzyme, you're out of balance and you're promoting breakdown. In addition, cigarettes interfere with this enzyme and you can get an imbalance. And so this is how emphysema from chronic smoking can result, because you're breaking down the extracellular matrix. In addition, we'll talk about chronic bronchitis, where we have an overproliferation of mucus happening. These are both examples of chronic obstructive pulmonary disease, where the airway resistance is extra high. Now, asthma or reactive airway disease is a problem where, because of inflammation, the airways spasm. And so that causes the airways to get too small, and you get really high airway resistance. And it doesn't matter if you're trying to bring the air in or you're trying to get the air out, your airway resistance is really high. And so it's important to realize there's a huge inflammatory component to asthma, and so some of the treatment means of asthma is centered around the inflammatory response. So here's some alveoli and a bronchiole in a healthy person, and then here we have a person with obstructive disease. So the alveoli are blown up, there's a lot of air trapping, there's some mucus, we have small airways. So we have a lot of, we have a high airway resistance and we have some air trapping. Remember how we would figure that out? Or how we could get a measure of that? We could measure FRC with the body plasmograph and with helium dilution, and we could compare the results. So here is an airway. You see the epithelium. You see some lymphocytes that are going to produce inflammatory substances. We also have some mucus-producing cells in the epithelium, and then we can get some mucus plugs. And it's entirely likely that people have both the mucus plugs and the inflammation, as well as the breakdown of extracellular matrix. So there are people that have COPD that have both aspects of emphysema and chronic bronchitis in their lungs. And so remember, when we test for chronic obstructive pulmonary disease, we want to use dynamic tests. So here's our peak flow, here's our healthy person, and as they exhale they build up to a peak flow, and then you have the expiratory flow, that the slope of this line and flow per second versus volume. So this is inhalation. Notice there isn't really a problem with inhalation with this person, but when they exhale, they have a much lower peak expiratory flow rate, and and their forced expiratory flow, remember from 25 to 75% of vital capacity, that slope is much, is much lower than this particular slope. All right. Now, we have another test of dynamic function. In addition to FEF 2575, we have percent FEV1. So here's our healthy person. This is what they breathed out in 1 second, and they keep breathing and they keep breathing and they keep breathing. So they get a ratio between these two. Now, our person with COPD, they breathed out 2 liters in a second, and they breathed out 3.9 liters total, which gives them a percent FEV1 of 51%. Now, remember what we want it to be? We want to be more like 70, or really more like 80%. So this person has a reduced percent FEV1. So both of our FEF 25 to 75 and our percent FEV1, both tests of dynamic function are showing that this particular patient has an extremely high airway resistance. Now, what can happen over time with lung volumes? All right, so here we have a person. Remember, we have a residual volume that's always staying in the lungs. We have our tidal volume. We have our expiratory reserve volume. We have our inspiratory reserve volume. We have an inspiratory capacity. We have a vital capacity, right? So you see the relationship of these values. Now notice, as this person gets COPD, it looks like the lungs are getting bigger and total lung capacity is getting greater. And it looks like tidal volume, I'm not seeing a huge change, though tidal volume looks bigger in this particular case. But notice what's happening to vital capacity or inspiratory capacity in this situation. Do you see how inspiratory capacity and forced vital capacity or vital capacity is getting smaller? So if the air we can move is getting smaller, but our total lung capacity is getting bigger, how the heck is that happening? Well, notice what's happening to residual volume. This person has more and more air that they cannot blow out. And notice as they reach more and more air that they cannot blow out, they're experiencing dyspnea. Dyspnea means shortness of breath or difficulty breathing or feeling breathless. So this person may have high CO2, which would contribute to that. They may have some hypoxia that's contributing to that. They also may have some congestion. They may have some hypoxic vasoconstriction that's increasing hydrostatic pressure, and that's stimulating the J receptors. So there are 3 reasons why this person could be feeling shortness of breath as their disease worsens. All right, now here's a clinical designation that I don't really think about as a physiologist, but I will share with you, those of you that are interested in clinical things. COPD can be divided into emphysema and chronic bronchitis, but it also can be divided into how well people maintain homeostasis. So we have a group of people that are called blue bloaters. What the heck is going on? Well, they have reduced PO2s. They're breathing more, and they're working harder, and they're feeling shortness of breath, and they just can't work hard enough to get a normal PO2 and a normal PCO2. Whoops, I need a CO2 in here. So when you aren't oxygenating well, you get to a point where you have hemoglobin that's not oxygenated, and people get that blue appearance around the lips. It can even be more pronounced than that. It indicates something called cyanosis. This person is got hypoxic vasoconstriction. There's having some effects on cardiac output and fluid backing up and that sort of thing. And they have a chronic cough. These folks tend to be the chronic bronchitis people. This guy looks like he's trying to do some pursed lip breathing. I don't know if it looks like that to you. But a blue bloater is a person with COPD who is not able to work hard enough to maintain normal blood gases. The other type of person we have is a person called a pink puffer. So pink puffers, they're working their behinds off. They're using their accessory muscles. They're using pursed lip breathing. They might not have the cough so much. They lean forward in kind of a tripod position to get the best oxygenation. So these guys are able to work hard enough to maintain homeostasis. So for a while, they've got normal oxygenation and normal PCO2. Now this guy's also on oxygen, so that's helping him to do that. But this is really, the designation is about homeostasis. You have a disease, you can work hard enough and maintain homeostasis. You're a pink puffer. If you can't work hard enough to maintain homeostasis, then you end up exhibiting the signs of a blue bloater. So how do you deal with COPD? So here's a person, their percent FEV1 is at 70%. That's not terrible. You know, we want it closer to 80%, particularly if that's their, if that's what would be predicted from their age and their gender and their body size and all that sort of thing. So you want to make sure that they're getting a flu vaccine, and they may need a rescue inhaler. Now, as the disease increases, it continues to be less than 70%. And so maybe it's getting on towards 50%. Maybe they have a rescue inhaler, but then they have another bronchodilator that they take. And then that continues, and then their disease gets worse. Then you're going to add maybe add steroids to help with the airways collapsing, and then you continue on, and the airway disease gets gets worse. Then add oxygen. And then consider surgical treatments. This actually came up in class the other day. Maybe having surgical treatments where you would remove disease areas of the lungs and see if the person can maintain better respiratory function. All right, reactive airway disease is sometimes a term used. Sometimes people have a temporary kind of asthma we call reactive airway disease. They've had a terrible respiratory infection and their airways are reactive. Or people can have more long-term where they have asthma. So we have proliferation of the mucus glands. We have a narrowed airway. We have some hypertrophy of the smooth muscle in the airways. So there's a component of increased airway resistance, and there's a component of increased inflammation. So when people have an asthma attack and they're spasming, that of course causes extremely high airway resistance. At first they may breathe like crazy. Well, they will, they increase their respiratory rate, they're trying to breathe, they're wheezing, that sort of thing. And they actually may blow off extra CO2 and get a little alkalotic. And then, then they cross into an acidosis, because even though they're breathing more, they're not blowing off CO2 the way they need to, and it's actually lowering their pH. There are people that we know why they have asthma, and there are other people that we don't know why they have asthma. They have sort of an idiopathic, or we don't know what's going on. Some people have triggers, certain allergens or the cold or that kind of thing. Other people, not clear why they have the asthma. When people have severe asthma attacks, they are often kept in the hospital because there can be sort of a bounce back, or a second asthma attack that comes on that's really, really, really horrible, and you don't want to be at home all by yourself, or parents with a scared child or that kind of thing when that second asthma attack occurs. So how would you treat asthma? Well, two things. You want to think about, how do we get the airways bigger, and how do we do with the inflammation? So it has been observed that people with asthma, with severe asthma, with damage to their endothelium, have a high level of eosinophils. So steroids would be given to help with that. The parasympathetic nervous system is going to have some immune effects. It's also going to have some effects on the smooth muscle. So you'd want to block acetylcholine, steroids to block mast cells, degranulation and allergic reactions. There are a category of what we call eicosanoids. These are lipid derivatives. And leukotriene, so leukotriene inhibitors is a fairly new category of drug that's used. Histamine blockers to again block the allergic reaction. And then going after the smooth muscle contraction, so beta-2 agonists. Theophylline is a phosphodiesterase inhibitor. Both of those things would increase cyclic AMP and promote smooth muscle relaxation. Or, of course, muscarinic agonists to block acetylcholine. And then secretion and edema, and again we'd bring in the steroids. So, something I'd like you to think about. Why is asthma in the same category as COPD, and how is asthma different from COPD? So think about that, talk about it with your group in class, and see if you can come up with some big similarities and big differences. All right, we also want to talk about restrictive disease. Examples, cystic fibrosis, at least in the long term, tuberculosis, sarcoidosis, ARDS, and then pulmonary embolism. How do we get pulmonary hypertension when you get a pulmonary embolism? Primary versus secondary pulmonary hypertension, and how weak this can go into heart failure. And pulmonary hypertension causes smooth muscle hypertrophy, and there's a significance to that. All right, so cystic fibrosis is a disease where there's a mutation in a chloride channel. There are over 1,000 different cystic fibrosis mutations. Some of the genetic sort of commercial testing packages test for the most common 500. So you could have a child that's got a bunch of mucus and they're not breathing very well, and is this cystic fibrosis, and how are we going to figure that out? And you give them a genetic test and it's negative. Does that mean they don't have cystic fibrosis? No, that means they have one of the rarer, or that could mean that they have one of the rarer alleles for cystic fibrosis. So initially, there's a lot of mucus. So really, initially, this starts out as an obstructive thing because mucus is clogging up the airways. The deal is this mucus is thick, and it's basically a growth medium for bacteria. So then these folks have infection after infection after infection, and you get all sorts of inflammation and scarring. And so in the long term, cystic fibrosis is a restrictive disease where compliance is decreased. Tuberculosis is caused by a bacterial infection, and the bacteria is really, really sneaky in that it fools the immune system, and the immune system can't really kill it, and so it walls it off in these little tubercles. And then people may wall it off, and they feel that it seems like they get bigger, they get better, and then later in life maybe they get sick again, and these tubercles kind of wake up, and then next thing you know, people have tuberculosis again. This is a horrible worldwide crisis because there are many, many antibiotic-resistant strains of tuberculosis. People don't have access to medicine. You have to take a couple of pretty powerful antibiotics, and you have to take them for several weeks. And you may not have the money for that. You may not have access to that. You may not be in a position to keeping track of medications, and so this is a huge global health issue. Sarcoidosis. Goodness knows what causes this. There's some kind of inflammatory process. People used to think it was some kind of bacteria. People used to think it was maybe asbestos or something like that. Nobody knows what causes sarcoidosis. It causes terrible lesions in the lungs, but it can cause lesions elsewhere, in the eyes, in the muscle, in the heart. It causes all kinds of problems. And really, what you can do, you give steroids to try to manage the inflammation, and maybe give oxygen. It's very difficult to treat. Idiopathic fibrosis. Peter Bitterman at the University of Minnesota is not only a fabulous pulmonologist, but he studies why people get fibrosis. Now, if you look at the population as a whole, as people age, they actually tend to get more of an obstructive kind of thing because their extracellular matrix breaks down. People's chests get bigger as they get older, that kind of thing. But there is a population of people that are more likely to get fibrosis, and why is that? Nobody knows. It's also a wonderful researcher, Angela Mortari, who is working on pulmonary disease. She's actually trying to grow new lungs. And she's trying to figure out what the nature of the extracellular matrix is, and maybe how to take lungs and populate them with new epithelial cells so you can make a lung instead of waiting for a lung transplant. Just all kinds of exciting science going on here at the U of M. ARDS, a couple of things. Lots of people can cause respiratory distress. Certainly, if you have infants that are born prematurely, they don't have enough surfactant, and they get infant respiratory distress syndrome, and they have to be put on a ventilator and given oxygen and given surfactant and that sort of thing. Most of the time, giving surfactant is really, 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 really beautiful because there isn't anything wrong with their lungs per se. They don't have surfactant. The thing is, if you're an adult and you have acute respiratory distress syndrome, something horrible happened. You aspirated vomit. You were exposed to noxious chemicals. I mean, something really, really bad happened. So giving surfactant doesn't really help because there's just so much awful damage. So the nurse anesthetist can certainly attest to needing to protect the airway while you're getting somebody ready for surgery to make sure vomit and other things don't get in the airway, and you can get that intubation tube in, and so protecting patients from this kind of thing. When you have an emergency and they might have to do surgery and they ask how long it's been since you've eaten, oh my goodness, they really need to know that, because if you ate 5 minutes ago, you know, they have to protect your airway from what you just ate 5 minutes ago. If it's been 12 hours since you've eaten, then the issues are a little bit different. So mortality rates for adult acute respiratory distress syndrome, it's really horrible. So there's a lot about being aware and prevention and that sort of thing. So all of these diseases have restrictive profiles. So what do we want to think about? What would a flow diagram look like for this person? All right. Remember, what would their peak flow look like? What would their FEV1 and their percent FEV1 look like? What would their lung volumes look like? What would a compliance curve look like? And what would you need to think about in terms of treatment? And certainly there are things unique to the disease, but what would you need to think about in general? And maybe we can take a moment to discuss this in class. All right, now, pulmonary embolism. So pulmonary embolism is an extension of a person that's having a problem with clotting. Now, why might a person clot? It could be that they don't have good blood flow. So there's a stasis in blood flow. Maybe they've been in bed for many, many days, or people on an airplane and they've been sitting in an airplane seat for 18 hours or some silly nonsense, and they're not getting up and moving around. And stasis of blood flow makes one vulnerable to clotting. I mean, maybe people have more clotting factors, or they have some kind of mutation that makes them more coagulative. So an example of a pretty common one is factor V Leiden. People are more hypercoagulative because of their genetic profile or something. They smoke and they take birth control or something like that. And then damage to the endothelium, which makes it more likely that somebody would have some kind of clotting incident. So then a clot breaks off, it's going to get stuck in the lungs. Now the thing is, that's what your lungs are for. They take those clots and they filter them out and take them apart. But what if it's many, 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 many clots? Or what if it's a gigantic clot that's really causing a lot of problems? Then that is a difficult. So in the lungs, remember, there's just all kinds of substances that are being made, and when the clots block the pulmonary arteries, some inflammation and activated platelets are set off, and then you get all kinds of vasoconstrictors released from the platelets, and you get some hypoxic vasoconstriction, and that leads to pulmonary hypertension. So then this ends up being a restrictive profile, and so people are short of breath and very fast respiratory rate, something called tachypnea. And we've talked before, somebody's breathing really, really fast, and why would they do that? And you say, can you take a nice deep breath for me? And maybe they can't. And so if this comes on suddenly, something to suspect is an acute situation where the person has a pulmonary embolism. And I look forward to some of the comments that our nurse anesthesia students would have to make in class. Alrighty, so pulmonary hypertension. Pulmonary hypertension can be classified as primary or secondary, as you see on the slide here. If you have primary hypertension, it means that you have high blood pressure in the lungs with a normal wedge pressure, meaning it isn't happening because blood is backing up into the lungs. So you can take a catheter and insert it into the blood system, wedge it into the capillary system, and then you measure something called wedge pressure. It is an indication of influences of the systemic circulation backing up into the lungs. So if you have a normal wedge pressure and a high pulmonary hypertension, that would be classified as primary hypertension. So person's going to have tachypnea because there's high pressure, high capillary pressure in the lungs, and that's a restrictive situation. They'd have shortness of breath. Certainly they would feel tired because they're not oxygenating well. There could be backups into the systemic system, and so you'd expect edema of the peripheral structures like the legs, increase afterload on the right heart, and we get concerned about the reversibility of pulmonary hypertension. Remember, you have smooth muscle in the walls of blood vessels, and when that smooth muscle hypertrophies, then your pulmonary hypertension has become irreversible. Very important treatment of pulmonary hypertension is things that increase nitric oxide. So things like Viagra. Viagra ends up being a pretty good thing for treating pulmonary hypertension because it helps deal with the pulmonary hypertension. You can give nitric oxide or give drugs through inhaling. It stays in the lungs, and then nitric oxide has a short half-life, so then it doesn't cause systemic hypotension. So there are lots of things pulmonologists have to think about when they're thinking about pulmonary hypertension. So what about secondary? It's because blood is backing up into the lungs, or because of pulmonary disease and hypoxic vasoconstriction. So if there's something wrong with the left heart and there's blood backing up into the lungs, if there's some kind of septal defect and the high pressure left blood is shunting over to the lower pressure right, if you have hypoxia because of chronic obstructive pulmonary disease, then you're going to have hypoxic vasoconstriction. The pulmonary embolism situation we just talked about on the previous slide would cause secondary primary hypertension. Now, let's get back to this work of the right ventricle. Oh, so wedge pressure is the key to differentiating primary and secondary hypertension. We'll talk about that in class. All right. So pulmonary hypertension increases the work of the right ventricle. Remember, afterload. So you're asking the right ventricle, which is not built for a high afterload, to work against a high pressure. And the right ventricle dilates, it hypertrophies, it fails. This is a condition called cor pulmonale, and this is obviously life-threatening. So the blood is going to back up into the systemic veins. So again, we'd expect edema in the legs. The jugular veins in the neck are going to be sticking out. Congestion of blood in the liver and a distended liver and that type of thing. So something that I really hope everyone can come away with is that you have chronic bronchitis. You have difficulty oxygenating. Remember, you're a blue bloater. And so you have oxygen levels that are less than 60 millimeters of mercury, and you have CO2 levels that are really, really high. And you get hypoxic vasoconstriction. That hypoxic vasoconstriction is all over the lungs. That increases the right work of the heart, and then the right heart fails. that is a very common progression, or that's a pathway of pathophysiology that I hope everyone understands very well at the end of this session. So here we are. We have finished the lungs, and hopefully we will finish the lungs in class, and I look forward to our discussions. Thank you all for working so hard, and I'll see you in class. Bye for now.